Hello, everybody. I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and welcome to Two Shrinks and a Mic. Today, we are going to discuss one of the anxiety disorders called obsessive compulsive disorder and some related aspects of that where a person may not actually have obsessive compulsive disorder, but they may obsess and they may be a bit compulsive and they may overthink. So we'd like to cover that today, both in terms of what it's like to have it and what we can do to help it.
And to make a comprehensive review of this topic, we'll probably be both obsessive and a bit compulsive, which I think is part of the job description for mental health professionals. Yeah, I tell people all the time that being obsessive is not a terrible thing. It's a helpful blessing and a curse, as I may have mentioned in a previous podcast. And dotting the I's and crossing the T's can be helpful in all aspects of life, from career to school to family, etc. But when it gets to an extreme, it becomes really problematic. And one of the hallmarks of obsessive compulsive disorder is the presence of obsessive thinking, where you can't turn your brain off, where there's nothing but redundant, broken record thinking, worrying about nonsense, things that are not critical, or worrying about things over and over and over again that makes no sense at all to you.
Some of the things that people might worry about or obsess about are things from the past. They could be more immediate things from the past, like that meeting that I had this morning. Did I say the wrong thing? Was I accurate? Was I smart? Maybe I offended somebody. Or it could be somebody's obsessing about something that happened 30 years ago. I once saw a man who, when he was in his 70s, he was still obsessing about that maybe 40 years before that, he wasn't sure if maybe he ran somebody over. And there was no reason to think that he did, but he started to have the thought, maybe I did, maybe I didn't realize at the time, and how would I find out if I did? And 40 years later, he was still thinking about it. So it could be about the past, or it could be obsessing about something in the near future or a long-term future. But the main thing is, as you said, David, it's like you can't stop thinking about it.
Well, that type of intrusive, broken record thought, like I could have run somebody over, or I'm afraid I could have killed somebody without realizing it, or having an intrusive thought of I'm dying from abdominal cancer. We call those horrific thoughts. They're really horrible. And very frightening to people because they're so irrational. People will say, I'm a pillar of the community, but yet I have these thoughts that I could pick up a knife and stab somebody. These individuals are not psychotic. They're not delusional, but it's almost as if there's a center of the brain generating this fear and this worry that keeps activating itself and putting these intrusive thoughts into a person's head. And it's horrible. And people with this type of problem will often keep it a secret, because if they say to themselves, if I tell you about it, you're going to think I'm absolutely crazy and put me away.
And everybody, as I tell all my patients, everybody has weird thoughts. Everybody has thoughts that are silly or stupid or impossible or disgusting or frightening. We all have thoughts. Most of the thoughts that we have during the course of the day make no sense at all, and they're not helpful. They're not relevant. But the brain churns out thoughts. And if you understand that many of our thoughts are just to be dismissed, then you don't worry about it. But if you have a disorder or a tendency to obsess and have these catastrophic thoughts, all your thoughts are evaluated and overvalued. So if by any chance I have the thought that I might want to run somebody over, that could be terrifying, and I might really start going down the rabbit hole and not be able to function.
We can't talk about obsessive compulsive disorder unless we talk about the C, compulsions, because that refers to another aspect of this disorder that is terribly troubling, because a person can become compulsive about being clean and stay in the shower for an hour in the morning and get to work late repetitively, or washing their hands repeatedly to the point of inflaming the skin of their hands to the point that they get infections, or having a desire to check repeatedly the front of the door of the house to make sure it's locked, not just closing the door and maybe checking it once, but going back 4, 5, 6 times. And even after you leave the apartment or the house, having that persistent nagging fear that the door must be unlocked. So compulsions are ritualistic behaviors that a person has no control over, that has to be done. And if you don't involve yourself in the action that's the compulsion, you're going to be tense, anxious, and feel very uncomfortable. Once you do the compulsion, that level of anxiety will decrease to some degree.
And on a temporary basis until you do it again. Most compulsions are connected to a what-if thought or a belief that if I don't do the compulsion or the behavior, something horrific is going to happen to me, to somebody, or something bad will happen. And if I do the behavior, even if it doesn't make sense, if I do the behavior, then it'll be better. Now, most of us have in our background some degree of superstitious thinking. I tell the story that when I was a very young boy, I think I was around 7 or 8 years old, I was in the same room with my mother and my grandmother, and I happened to sneeze. And they both said to me, okay, pull up your left ear 4 times. And I said, what do you mean? Why do I have to pull up my left ear 4 times? And they said, well, you just do it because even though you don't want to do it, it's a fact that if somebody sneezes while somebody happens to be talking about somebody who died recently, you have to pull up your left ear 4 times.
Yeah, but I had a grandmother that used to put garlic cloves in my pocket to keep the evil eye away.
Exactly. It kept people away for sure. But anyway, I refused to do this ritual. And to this day, I'm not superstitious. But most people are a little bit superstitious. But when it becomes something that really interferes with your day-to-day life, that's a version of obsessive compulsive disorder.
You know, most people with superstitions can push them away. And you see a lot of sports figures who will have various repetitive behaviors as a way of bringing themselves luck. They'll wear the same jersey at a game because they won the last game. But they can push those superstitions away. But individuals with obsessive compulsive disorder can't. And it becomes a recurrent process. And it really interferes with function. I mean, you hear people repeatedly saying that I'm not able to live the life the way I'd like to because of the fact that I'm stuck in my head, or I repeatedly have to wash my hands or take a shower or keep the apartment so clean that I'm up at 2 o'clock in the morning vacuuming because it's never clean enough. And it's automatic behaviors that can't be controlled.
I think that the main differentiating factor with obsessive compulsive disorder is the person's inability to tolerate uncertainty. Most of us have an ability to tolerate uncertainty. We feel much better if whatever that issue is, if we're close to 100%, if we're at 90%, 95%, we feel pretty comfortable. But the person with OCD, they really can't stand even the 1%. And that's the part that they focus in on and start to be terrified about, the 1%. Even if it's a less than a 1%, they require certainty. So that's involved in, did I lock the door? That's involved in, I know I went to the doctor and he said I'm okay, but what if he's wrong? That's involved with just about everything that a person with obsessive compulsive disorder is involved with, is that absolute hatred for uncertainty. So we try and help a person change some of that.
Related to that uncertainty concept is what I see individuals describing as horrendous self-guessing. They second-guess themselves. They decide that, I truly couldn't have done that the way that I wanted to, or am I sure I want to make this left turn, or is this answer correct for the exam I'm taking? But this is something that affects them all aspects of life. It's not just limited. I mean, I found myself when I took all the old-fashioned multiple-choice exams that I would always second-guess myself in those exams. And the way that I overcame that was for months I practiced at allowing the first answer that came into my head. And without realizing it, I was doing one of the things that we teach our patients to do, which is to do cognitive-type behavioral changes. But the second-guessing in OCD is just there all the time. And it's almost like you can't be settled with the answer that you think is the right answer. It just goes around and around and around and really interferes with the ability to proceed and make decisions.
It's involved with that what-if thinking as well. Like, what if this isn't the right choice? What if I didn't do it enough? What if I think it's the right choice, but what if it isn't? And it just becomes more involved with just about every aspect of living. And in some cases, it will be so dramatic that it will interfere with relationships. It will interfere with job. It'll interfere with just about every aspect of life, because a person really can become immobilized. There's concept with people who have obsessive compulsive disorder where they become literally paralyzed. They can't make decisions. And so they look to other people for reassurance. And reassurance-seeking behavior becomes very powerful, usually ends up not being enough of an answer either, because let's say if I had obsessive compulsive disorder and I looked for reassurance from you, Dave, I still might say, yeah, but maybe you're wrong. And maybe I should ask, Joe and Bob and everybody, but, they could all be wrong too. And then maybe I'm presenting it in a way where I'm presenting it wrong. I've had patients with clearly obsessive compulsive disorder, and when I explain it to them, they say, well, maybe I'm explaining it in a way that makes you think I have obsessive compulsive disorder, but maybe I really don't. So it's a very tough thing. And when you try to reassure a person about the content of the issue, you get nowhere.
The sad thing is that there are loads of folks who are walking around with, in the closet, so to speak, with obsessive compulsive disorder who are ashamed, embarrassed, and like I said before, if they tell anybody, they're going to think I'm crazy. They feel inferior, et cetera, et cetera. The individuals who tend to get into treatment tend to have the compulsions because it's so obvious. I mean, if you wash your hands repeatedly to the point that you're inflaming your hands, or you can't get to work on time because of taking showers, or because you become a hoarder in your apartment, you can't ignore that, and it's usually a friend or a family member will get you into treatment.
Yeah.
But the folks who are walking around with busy heads and the obsessive aspect of OCD oftentimes do that for years and years before they're able to get some help, which is a shame, because this is a disorder that can be treated and treated quite effectively. And that's a sad aspect of it, because if you can't finally get to be educated about the nature of treatment, you'll just suffer.
And it has nothing whatsoever to do with intelligence. It can affect somebody who is brilliant. I have had physicians who couldn't practice anymore because they were afraid that they would be somehow contaminated by some virus or germ, and they literally couldn't go to the office anymore because they were afraid that somehow they might touch something and they would die from it. I've had another person who was very religious, Catholic, who went to church to Mass every week. And one day she was sitting in church and she had this horrific thought that she might get up and run up and try to kiss the priest. And she was so absolutely terrified and mortified by the thought, she couldn't go back to church anymore, which made her feel worse because she felt she was sinning by not going. So you could see how quickly sometimes this thing cascades into all kinds of other problem areas. And that's why very often when I see a person or you see a person, their life is kind of fallen apart a lot. And so by the time they do come in, after hiding it and feeling ashamed of it and embarrassed by it, at some point it's just too severe to hide. And that's when we will get involved with people and start to treat them.
And those horrific thoughts, when they occur, are real to the individual.
Very.
I mean, they're just no different than the individuals who hallucinate, which is not part of OCD, but can be part of a psychotic disorder. And they tell you, well, I'm hearing that person talking to me. It's real. It's manufactured by the brain, but nevertheless, them is very real. So these horrific thoughts are so real to the individual that they frighten them, something terrible. And I've had individuals who has been a member of the community who will be at board meetings and city council meetings and have a fear that they could throw a glass of water at somebody at the table. And it's so real that they cringe when it happens, but don't want to tell anybody, because if I tell anybody about this, they're either going to lock me up or tell me that I'm out of my mind and psychotic. And it's a brain area that's generating these intrusive, horrific, unrealistic, but irrational thoughts.
Some of it has a social or cultural aspect as well. And about, I guess, 5 years ago, maybe longer, I wrote a book about something called HOCD, which is OCD about one's sexuality. And the obsessive thought is, what if, even though I think I'm heterosexual and I've always been heterosexual, what if I'm really not? What if I'm gay? Or what if I want to be gay? Or what if I'm somehow going to become gay? And that thought is not syntonic, it's not right for the person. They don't want to be, but they're so terrified that they might be that they become totally obsessed with it, and affects their whole identity. And they start to avoid people. They start to avoid being with people of the same sex because they're checking to see if they have any feelings or arousal. So it's a bad one, and it affects teenagers, it affects 20-year-olds, and it affects people who, in their 60s. So it's just another variation of the same theme with OCD, the what if and how can I be certain?
One of the variations that you're describing that I see most often is another H OCD, which is health OCD, and it's debilitating. Kind of reminded me of what's called medical student syndrome. When you're in medical school and you begin to learn about bodily function and diseases as a medical student, if you have a cough, the first thing think of is, could I have a lung cancer? And that kind of irrational thinking is prevalent, but over time you've learned how to put that away. But folks who have health OCD are just tortured by it, because if they have, a funny lesion on their arm, immediately they think that it's a cancer, and they may go to one doctor after another, despite getting reassured that it's nothing, and they just can't get that fear out of their head. Eventually it will leave, but then they'll have another health fear that becomes built in and reverberating in their heads and interfering with their ability to function. So health OCD is more than just hypochondriasis or psychosomatic type medicine. It's a obsessive process that can be debilitating.
Examples of it, even more so today because of the ability to go on Dr. Google and now AI. It causes people who have OCD about health to have a wealth of information, but never enough to get certainty. So, what I tell people is, if you start Googling runny nose, if you scroll down long enough, you'll find that could be cancer. And so the person who has health OCD is really in a bad way because of all of that. And again, we have to impress upon the person, it's not about the content, it's about how your brain with OCD will seize on something to become obsessive about. And that's the mechanism that we try and intervene on, whether it be with the cognitive behavior therapy work that I do, or the pharmacology work that you do, or both.
You raised a good point with the Dr. Google, because I see that all the time. And it's one way to differentiate what is a pathological obsessive syndrome from kind of normal neurotic obsessing. So individuals who get on Google or ChatGPT and look up a symptom immediately worry and obsess about it, and I call it pseudo OCD. But once they come in and try to reality test with a physician or with somebody who is knowledgeable about the problem and get reassured, they can put it away. But the individual with OCD, especially health OCD, can't, no matter how much you reassure them. And I've knew somebody from school years ago who was convinced that he had a venereal disease. And I'd known this individual 25, 30, 40 years ago, and had not seen him then for 30, 40 years, and bumped into this individual, and he still had that preoccupation to the point that he couldn't push it away. He'd been to every specialist you could imagine, every test you can imagine, every reassurance that would be reasonable, and it didn't change anything. It can just kind of visualize the circuitry going around and around and around, and it's a tough process and requires a lot of treatment.
Same. I once saw somebody who, she was from another state, and she was convinced that somehow she had uterine cancer. And she went to different doctors, and they all said no. They did tests, and no. And she was never satisfied with the fact that it couldn't be certain. So she said, well, how can I be certain? And they said, well, the only way you can be certain is if we do invasive surgery, and we won't do that. That's malpractice. So she came to see me for a few months, and she really was fine working with the OCD concept. 6 months later, she had it in her mind that maybe she got rabies one day years ago. And it flared her up again. And this time she wouldn't stop. And she found some doctor in the Midwest that for $25,000 gave her rabies injections. So it's so powerful. It sounds, when we talk about it, it sounds, if you don't have OCD, you say, oh, come on, how could you believe that? Well, if you have OCD, you're afraid not to believe it.
And people often have false beliefs about what treatment will accomplish. So they worry that if you take away my ability to be obsessive, I'm going to have a blank brain or a blank head. But I try to reassure people that what we want to do is to allow you to utilize the aspect of being obsessive that is positive and a positive trait, not negative. But we want to get rid of where you can't sleep at night because you can't turn your brain off wondering about whether or not your alarm clock is going to go off at this time that is set in the morning, or whether or not the check you sent in to pay you the electric bill got to the Florida Power and Light on time. So those types of pathological obsessions need to be addressed with treatment. But the person who successfully can work on that type of treatment still can be obsessive in a very positive and healthy manner.
A number of years ago, I had a patient who really had done much better and was starting to feel much less anxious. And one day came in to see me and said, I'm not feeling so anxious anymore, but I'm feeling anxious about the fact that I'm not anxious. And, it wasn't funny. It was because he was afraid that he was letting his guard down. In some ways, anxiety had become his way of protecting himself. And if he wasn't anxious, he might be fooling himself into thinking that danger was not around. So yes, as you said, there's different levels of what the person might go through, even when they're doing much better.
Over the years, I've been impressed that we need to think in terms of spectrum of disorders. One of the most common anxiety disorders is something called generalized anxiety disorder, or also known as the worry syndrome. But it is not OCD. But one of the ways of thinking about obsessive anxiety is to view it as a spectrum. On one end is the concept of OCD. At the other end is neurotic anxiety that needs to be addressed in old-fashioned exploratory psychotherapy that may generate from family of origin and the types of experiences you had as a kid as you were growing up. And then there's, at a higher level of intensity, this generalized anxiety disorder where there's excessive obsessive worry to the point of indecisiveness, inability to make decisions, causing upset stomach, tense muscles, restlessness, difficulty with sleep. But it's not the same as OCD. Very common, and maybe a function of our modern society and the stresses of our modern society. But OCD itself stands out as really very different and unique and requires a different approach.
Yeah, I think of it as an extreme variant of something we all have, which is, it goes back to when we talk about that survival instinct that we all have. And most of us are okay with our survival instinct being pretty strong, pretty good, and covering most things. But with the extreme version of that is, if there's danger out there, if there's threat, why do a half-assed job at it? I think I need to go 100% on duty and be perfect at it and make no situation have any degree of uncertainty. Now, that's not a conscious thought that the person has, but that's kind of like how the brain ends up working. And so our work is trying to help people realize you don't have to be perfect. You don't have to have 100% certainty to be safe and to enjoy your life. And we have different ways of doing that. I think what we'll probably try to do next time is go through some of the treatment methods that we know are effective for OCD. I'm not certain that we've covered everything today. Do you think we've 100% certain that we've covered everything?
Say that again. Well, one of the things that would make our jobs a lot easier is if we had our own functional MRI machines in our office. A functional MRI is different than a regular MRI because it can highlight the areas of the brain that are either overactive or underactive. And they've actually done studies, since it's a research tool, of individuals with OCD, and you can actually see the areas of the brain that are overactive when they're symptomatic. And what's absolutely fascinating is after treatment, whether it's pharmacologic or cognitive behavioral, those areas of the brain will now normalize, return back to their normal resting state of activity, which indicates really the fact for individuals that this is not necessarily something that you got from your mother or your father, or the nasty
Right.
teacher you had, et cetera, but it's really something that was built into your brain that is surfacing and needs attention and can go back to a normal level. But we will talk some more about this because we haven't really touched on the treatment.
Right.
And that's the good news. We've given you all the bad news, but the good news is that there is treatment and it does work.
And I'm certain that we'll do that next time.
And I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist. And
we are Two Shrinks and a Mic.
Thank you for
being here. Say it again,
here.
Sam.
Have a nice day. The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.